RSV Academy. Questions about RSV. How many children actually die of RSV?
Hello, we will now talk about RSV mortality in young children. So what do we know about RSV mortality in young children? We do know that RSV is a leading infectious cause of deaths in infants, and particularly it's second only to malaria. It's the true RSV mortality in infants is unknown, but it's estimated to be anywhere between 101,000 and 229,000 in children under the age of 5 years. The majority of the deaths occur in children younger than 6 months of age. So 45% of the deaths occur in children younger than 6 months, and 20% of the deaths in children 6 to 11 months. RSV mortality in infants is rare in high-income countries. More than 97% occurs in low and middle-income countries. But overall, there has been a decline in child pneumonia mortality in low and middle-income countries in the last 2 decades. So it's reasonable to assume that this may have had an impact on RSV mortality. Now, what has led to the decline in pneumonia mortality in children in the last 2 decades? It's primarily due to the improved socioeconomic standards in low and middle income countries, use of pneumococcal vaccines that are there, and also a lot of the other socioeconomic and demographic risk factors that are there for RSV that have improved as well. So, better nutrition, for example, that does contribute to reduction in overcrowding, that does contribute to reduction in RSV mortality. Most of the RSV deaths can be averted by supportive management through supplemental oxygen and hydration, and the care seeking and access to care and quality of care in hospitals all have an impact on RSV mortality. That is provided if the child can get to the hospital. Now, majority of the RSV deaths, for every 3 RSV deaths that occur in the community, 1 death occurs in the hospital. So the majority of the deaths, 75% of deaths, are occurring in the community, outside hospital. And there was a interesting paper from Natalie Mazur that was published recently in the Clinical Infectious Diseases, where they looked at the data from RSV deaths in community and in hospital, and this data set that they had over 600 deaths, of which 156 were in the community. So when we focus only on the children younger than 6 months of age, what they report is that children who were dying in the community, and they've shown in their paper, and if you're looking at the slides, then what you would find is that the community deaths have been shown in these sort of purple bars and the hospital deaths in gray bars. But the important message here is that the peak mortality that occurs in the community is earlier, so about less than 2 months of age, whereas the hospital deaths occur much later. And we will talk a bit about that in a moment. But if you were to look at the full data set, again, over 600 deaths, but if the children had to have lived up to 12 months of age, so these were children, the studies that included children up to 12 months of age, and then what you find is that the distinction is much less clearer. The important thing to note here is if you were dying in community, then you're likely to die around 2 months of age, and if you're dying in hospital around 4 months of age. The children who were dying in hospital more likely had comorbidity. So in their study itself, they report 46% of the children who died in the hospital had a comorbidity versus about 28% in the community. And then children who died in hospital are likely to be slightly preterm compared to those who die in the community. So in terms of gestational age, there was a significant difference. Now, let us look at the case fatality ratios in hospital versus community. Do we really know what the case fatality ratios are like? For hospital, yes, because the children get tested in the hospital, and there are lots of data points that are available. So I'm going to talk about the data that was reported in a meta-analysis that we did and published last year, what we found is that if you were to segregate the data by age bands, narrow age bands, 0 to 2 months, 3 to 5 months, 6 to 11 months, and 12 to 60 months across the 5 years. And if you were to stratify also by the income region in which the country lies where the study was conducted, then there is a clear gradation. So the case fatality ratio in hospital, so if the child was admitted to the hospital for an acute lower respiratory infection, was tested for RSV, found positive, and then the child dies. So then the children who died are common to the numerator, the children who are all tested positive for RSV and admitted to the hospital in the denominator, then the case fatality ratio is about 2.6% in the low income countries in the children up to 2 months of age. Whereas if you were to look at the high income countries, this is less than 0.5%. In the upper middle income countries, about 0.7%. But then if you were to look at within this low income region by age group, what you find is, again, the case fatality ratio decreases with rise in age. So by the time the child is about 11 months of age, the case fatality ratio has decreased from 2.6% to 1.8%. And in the high income countries, in fact, a lot of the mortality that occurs is occurring after the first 6 months of life. So the case fatality ratio in children who are 6 to 11 months of age is about 1.1% compared to 0.05% in children less than 2 months of age. And in the 12 to 60 month age group, it's about 0.2% compared to those who are in the 0 to 2 months of age. And the reason for this is that children who die in high income countries are most likely to be those with comorbidities. And therefore these children by the time they get infected with RSV and seek care, they may be dying from those a combination of factors, RSV and the comorbidity, than RSV alone. This is something to bear in mind, and this may have an important implication, particularly when deciding for immunization in these children. So some of these children who are older than 1 year of age may need to be immunized against RSV into the second year of life. The other thing to bear in mind is that what do we know about the difference in the case fatality ratios in the hospital versus community? Now, it's very difficult to measure RSV deaths in the community, primarily because if you want to measure case fatality ratios, you have to follow up children, you have to test all the children who get RSV, and then follow up until death. And this is very resource intensive, also very time consuming, and deaths are not that common from RSV, even in lower middle income countries. So overall, as I said, 101,000 RSV attributable deaths across the world. But there was a study that was done by Ashish Satav and Eric Simoes in Melghat in India, and they have really looked at the children who are getting RSV in a remote tribal population in Maharashtra in India and followed them up. And they report 9.1% case fatality ratio in this age group. So compare that with the lower middle income country case fatality ratio in hospital, about 1.8%. So and 9.1% in this data from Melghat. But the important thing to bear in mind is that the number of patients that were there who tested positive for RSV were 22 in this age group, and only 2 deaths. So as I said, that goes on to reflect the fact that these deaths are few and far between. Then between 3 to 5 months, the case fatality ratio decreases. It's about 3.3%. So again, when you were to compare that with what you see in the hospital, is about 1% in the hospital and 3.3% in the community. But again, these are based on very few data. So 30 children who tested positive for RSV and only 1 child died. So what does that mean? The children who die in the community from RSV are younger. They are born term at birth. The majority of the RSV deaths in the community have no underlying comorbidity. So these children are essentially healthy children. They don't have any of these risk factors that we talk about, which are applicable to high income countries. The case fatality ratio due to RSV is higher in low and middle income countries, both in hospital as well as in community. And estimating the case fatality ratio due to RSV in the community is very challenging. Therefore, the true mortality burden remains unknown, and the only way you can uncover this is by using vaccine probe approach or well-designed vaccine impact studies, where you give vaccination to the children and do a comparative before-after study, or you have a control population which is not immunized, and they again sort of compare the mortality in that population. But otherwise, it's very difficult to understand the mortality that is attributable to RSV in the absence of very well-designed case control studies. Thank you for your time.